Good evening. Thank you all for coming. My name is Paul Apostolides. I'm a neurosurgeon and one of the spine surgeons here at ONS. And thank you all for coming to Ask a Spine Doc tonight. We've already had a couple questions submitted earlier before the presentation. And I'm happy to answer any questions that I get during the presentation. I brought a few slides to help us with a little bit of anatomy, because a lot of times the spine's a little difficult for everyone to understand. So the first question that I was asked about is a problem called spondylolisthesis. Okay, and I'm going to show a little bit of anatomy here, which is the lumbar spine looking from the side, and they're numbered appropriately L1 through L5 and then to the sacrum. And you can see that the alignment of the spine is perfect here. This right here, all the way down, is perfect. And when we look at spondylolisthesis, I'll find it in a second. Here's an example of spondylolisthesis. So spondylolisthesis really means that one of the bones is slipped forward of the other bone. So you can see here that the alignment is coming down. And you can see that there's a slip of this bone in front of this bone right here. And that's really technically an unstable condition in the spine. And most of the time when people have spondylolisthesis, a lot of times they'll have spinal stenosis. And so spinal stenosis is narrowing of the canal where the nerves live, which basically means that the nerves get tight, and that causes back pain and that causes leg pain. And there are a number of treatments for spondylolisthesis, but definitive treatment is surgical. And the surgery involves decompressing the nerves, and it also then involves stabilizing the spine. But a lot of patients come with spondylolisthesis, and they don't necessarily need surgery right away. It just depends on their symptoms. So a lot of times when we see patients, basically conservative treatment would include physical therapy. I'm going to stop that for a second. Would include physical therapy. Sometimes epidural injections can help, and sometimes they help for a long period of time, and sometimes they only help for a short period of time. Getting in shape, so losing weight, working on your posture, sometimes making sure that you're sleeping on a firm mattress. All of these things can help to some degree, but in the end, spondylolisthesis and spinal stenosis, which usually go together, definitively need surgery to treat them. And again, the treatment for it is really to remove the bone to free up the nerves, which is what's really causing the leg symptoms, and then to stabilize the spine by putting in a couple of screws at each level and locking them together in order to stabilize the spine. Let me go back to share. I'm just sharing. So here is a picture of myself doing surgery, and this is a minimally invasive approach to doing the surgery for spondylolisthesis, which allows us to decompress the nerves and to decompress the nerves and then to lock it together. And here you can see a spacer in the middle, and the two screws on one side, the two screws on the other side, and the little rods that hold everything together. This is looking straight on, this picture. This picture is looking from the side, and you can see the spondylolisthesis, which was a little bit bigger, is now reduced where it's more in line, and you can see that it's stabilized. This is just a CAT scan picture showing the screws going into the bone, the little cage here, and then the other set of screws down below. So hopefully that answered the question of spondylolisthesis and stenosis. Another patient wrote in asking about Huntington's disease, and that is more for neurology, not for neurosurgery or spine surgery. So Huntington's disease is generally treated by neurologists, not by neurosurgeons. So while I'm waiting for any other questions that y'all feel that you want me to answer, I'm going to go ahead and show you again a little bit of the spine anatomy so that we can understand what we're really seeing. Again, here's the spine now in an anatomical view. This is a vertebrae, and then this is the disc that is the cushion between the bones here and here. Oops, let me get that back. And so when you see the disc, it's really made of two parts: the outer part, which is a tough fiber, and the inner part, which is more of almost silly putty. And that disc is what tends to come out if you have a disc herniation. This will leak out here and put pressure on a nerve. And people always make a mistake in the lumbar spine and think that it's the spinal cord down here in this area, but the spinal cord ends up high here. And I always like to think of I-95, the shoulders, and the exit ramps. I-95, let me just stop that. I-95 is really just, if you think about this space here, the nerve rootlets are dangling in a sac. And then at every level, a couple nerves go out, and then they go down into the legs where they give innervation. And so a lot of the problems in the lumbar spine have nothing to do with the spinal cord, which is really up high, and they're all down here. And this is kind of how it looks. You know, I think of I-95, the shoulder, and the exit ramp of the nerve coming out. Oh, let me see, there's a couple more questions here. Someone just asked, does ablation help spondylolisthesis? And the answer is, ablation is just one tool that the pain management physicians can use to try and mitigate back pain from a number of conditions. Most of the time, ablation is secondary to an injection in the joint. So let's just say you had back pain. Let's say you had arthritis of a joint, which in a lot of times people with spondylolisthesis have. That joint can in and of itself cause pain. And so usually the pain management physician, if they were going to want to know, hey, does that joint cause problem, can inject that joint with some steroid and some numbing medication. And if the patient says, hey, I got a lot of relief from that, then the second step wouldn't be to redo that again, because that's more of a temporary measure. They do an ablation, which is they cook the little nerves that go to the joint, around the joint, and hopefully that gives patients longer relief. In patients with spondylolisthesis, the problem is it's an unstable condition. It's not the primary problem. So ablation tends to be used more in patients with chronic low back pain with degenerative changes, but no real obvious structural problem that would be amenable necessarily to surgery. So it's not often used. It can be used to mitigate some pain, but it's certainly not the definitive treatment of spondylolisthesis. And it's also not the treatment of patients with spondylolisthesis and spinal stenosis, because that it does nothing to alleviate the pressure on the nerves. So I had a great question. What are some of the most serious side effects from spinal surgery, worst to best? So I'll take that in a couple parts. One is there are many types of spinal surgeries. So most of the time we're doing surgery for degenerative conditions or for acute conditions, for example, disc herniations where a nerve is being pinched, spinal stenosis where I-95 is tight and the nerves are being pinched, spondylolisthesis, which is an unstable condition. But then you get into even more complicated problems such as fractures, tumors. Tumors can involve the spine bone itself, or they can involve the nerves, they can involve both. And so the complication, although similar, the risk profile is different for each of those surgeries. So I think that you know, the likelihood of bleeding problems related to a lumbar disc surgery is very minimal. As you do bigger cases, for example, tumor cases or fracture cases or larger degenerative cases, scoliosis cases, then the risk of blood loss goes up. So I think that, you know, I always tell patients the risks of surgery are bleeding, infection, death, coma, paralysis, and anything bad you can think of. The likelihood that any of those are going to happen is very small. It's not zero. And I use the example that we fly on a plane and the risk is potentially dying, but the risk is so small that it's worth taking the risk to fly to where we want to go. I think whenever you're putting hardware in patients, right, when you're stabilizing something, the risks of doing an instrumentation to put the hardware in and to do a fusion to have the bone heal is failure of the fusion. You could do everything right and the bone just doesn't heal. Sometimes patients have osteoporosis. Sometimes patients have diabetes, don't heal as well. Or you can just do everything right in a young person, it doesn't heal. So failure of fusion, failure of hardware. Usually the hardware is very well made. If you ask the hardware to hold stresses, particularly in tumor cases or in patients with very osteoporotic bone, sometimes the hardware itself could be stressed and break. If you think of a coat hanger, you could bend it 10 times and maybe break it. You could bend it 1,000,000 times and then it might break, but eventually it'll break. So the hardware itself is meant to hold the spine together till the fusion occurs. The hardware could loosen, the hardware could stay in position, but the bone itself might be weak. And so you can have a loosening of the hardware, or you could put the hardware in the wrong position called malposition of hardware, which is, again, unlikely. I think if you're operating in the cervical spine, the biggest risk is spinal cord injury. It's rare, very rare, but it can happen. I think in the lumbar spine, there's not a spinal cord, but you could obviously injure the nerve roots that go to any part of your leg, or you could injure the nerves that go down to the sacrum. And so going to the bathroom, peeing, pooping, all that stuff, you could potentially injure. But I'd like to emphasize that those risks of surgery are very, very small. They're not zero. Anyone who tells you zero is, I'm not sure what they're talking about, but they're very, very small. So hopefully that answered that question. I just had another question. What will determine if you need surgery for stenosis and spondylolisthesis? And so my feeling about that is when you cry uncle, it's time to have surgery. And so the reason that most patients have surgery for spondylolisthesis or for spinal stenosis, but usually it's related, they're both, is when the symptoms, when they can't live with the symptoms. Usually it's leg pain. So most of the time, for example, with spinal stenosis, patients will tell you, you know, when I sit or I lay down, I feel great. As soon as I stand up and walk, my husband's telling me I'm leaning forward. I feel really good leaning on a grocery cart. If they take the grocery cart away, I used to be able to walk, 50 blocks. Then I could walk 25 blocks. Now I can walk 10 blocks before I have to sit down. And now I'm really having trouble getting to the car, getting to the grocery store. And that's a reason that someone would rationally say, okay, I need to fix this. And that would be true of spondylolisthesis and stenosis. But usually it's when you cry uncle because the symptoms are just affecting the quality of your life in such a way that you can't live the life that you want to live. Another question, is there anything that can be done to stop or slow down degenerative disc disease? So degenerative disc disease, I hate the word disease because disease, it's not a disease, it's aging. So the same question could be asked, is there anything you can do to stop or slow down aging? And the answer is no. But we know that for back pain, and this would probably be somewhat true for degenerative disc disease, is weight control. So keeping your weight down is very helpful because too much weight, if you're overweight, that's a tremendous stress on the lumbar spine. So losing weight is always good and can help back pain. And it may not change a genetic predisposition to degenerative disease, but it can definitely help patients with back pain. So weight control is good. Posture control, sitting properly in the chair, moving back in the chair, sitting up straight, walking straight, not leaning forward, scrunching around. We know that that helps. Making sure that your mattress is firm and not 20 years old and saggy, and that can cause back pain. Doing back abdominal exercises on a routine basis, again, can help. And not smoking. We know that smoking can cause back pain. It can affect the spine. It definitely interferes with fusion. You have a 35% less fusion rate if you smoke it versus if you don't smoke. So I think those are the only things you can do. Degenerative, there are some people who are in their 20s who have terrible degenerative disc disease, but they have no symptoms. And there are people who are 80 who have perfectly looking spines, and it's kind of variable. It's just a bell-shaped curve. But really, it's kind of staying in shape and being active and doing a home program, that workout program that keeps you mobile. Because I think as you start to not be mobile, then things tend to slow down and you start to advance. Next question. Hopefully that answered the question. If foot numbness persists after a laminectomy and new numbness starts in the other foot, does that mean that there's a need for another surgery to deal with the new numbness in the other foot, no other symptoms? So I'm assuming that you had numbness in one leg and then you had surgery for that and you had some persistent numbness, and now at a time later, you've developed numbness in the other leg. So what I tell patients, in general, we don't operate for numbness in general, although some patients who have spinal stenosis tend to complain of numbness, but it's really a word that we use, paresthesia, is like when you hit your funny bone, you get that weird feeling in your arm and you don't like it. And some patients with spinal stenosis, when they walk, they say, I have this tingling, weird numbness in my leg, but it's painful. And that a lot of times that's paresthesias. And sometimes they have true numbness. When you examine them, you say, oh yeah, your foot's numb. And I always tell patients that pain goes away first, weakness goes away second, and numbness and tingling may or may not ever go away, because the nerves are divided into two nerves. One is the motor nerve and one is the sensory nerve. And the motor nerve is myelinated. So it's like going outside in this storm we had the other day, but wearing a parka. The sensory nerve is actually going outside naked. And so who's going to get damaged first and who's going to take the longest to get better? So the sensory part of the nerve tends to recover at a much slower pace. And by the way, you recover from a nerve injury, from a disc or a pressure on a nerve at 1 millimeter a day. So if you think about a problem in your back and you have a numbness of your foot and you just do the math, it could take a year for the numbness to get to the maximum improvement that it's going to be, sometimes up to 2 years. But if you had new numbness in the other leg a time after surgery, then that would indicate that you need a new MRI to make sure that you don't have a new issue that needs to be addressed. I don't know that it needs surgery, but it might need to be addressed, might need an injection, might need physical therapy to help. Hopefully that answered your question. Degenerative changes at C1-2 with erosive changes around the dens and marrow edema around C2-3. What does this? Celebrex minimally effective. So a lot of people have degenerative changes. So C1-2 is at the top. Let's see if I have a picture at the top of your spine. I'm just looking for a picture here. I think this guy. So this is C2 right here, and this is C1 ring up here. We're talking at the top of the spine here, is what the question's asking. You can have degenerative changes of the C2 bone. That's not uncommon, which is the dens. The dens is this part right here. And you can have some edema of the facet joints, and MRIs are really good at picking this up. And the question really is that symptomatic or not? Because sometimes when we get an MRI, we see things and it's either we're looking for that or it's just an incidental finding. But for example, if you had pain in the right side of your neck and had an MRI showing edema of the C2-3 joint, then that would mean that the C2-3 joint could be inflamed, and that might be worth pursuing either oral anti-inflammatory medications, sometimes oral steroids, physical therapy, and even sometimes facet injections, an injection that the pain management doctors do under X-ray that goes right around that joint to try and calm it down. And sometimes if that works and then it came back, you could try an ablation that we talked about earlier. The only reason to really operate up there is if someone has degenerative changes that are bad enough in the dens that are pushing on the spinal cord, or the C1-2 level is unstable. Those are two reasons that we would consider operating on it. But we see a lot of patients who have degenerative changes there with some neck pain, and usually you just treat that conservatively, unless the spinal cord's compressed or unless they're unstable. Then those are reasons to really work on it. The patient wrote, Celebrex minimally effective. So Celebrex is a non-steroidal anti-inflammatory. You could certainly try an oral steroid, do the physical therapy. If that doesn't help, then talk to a pain management doctor about whether or not an injection in that joint would be helpful. So back to ablation. Is there a downside to the procedure, not including it doesn't fix the pain issue? So the only downside really is that the risk is very minimal, but an infection would be a downside. Obviously, you don't want people sticking needles in you for no reason. I think the risk is minimal and the benefit is unknown. I think that I tend to use facet injections or send patients to be evaluated for facet injections if they have significant degenerative changes of their back and no real obvious surgical issue that needs to be addressed, because it's really for kind of chronic back pain. If you have spondylolisthesis or stenosis, or your spine's unstable on x-rays where we bend you forward and backward and see instability, you can do that, but that is not a definitive treatment. The second question, by dealing with symptom but not underlying cause, could things get worse? So here's the thing, we treat you, not the picture. Because if we took pictures of a lot of people, we'd see a lot of degenerative changes, and we'd have a lot more work to do. But really, we have to look at you. And there are patients who have very degenerative spines who are doing fine, and then there are other patients who have one level that looks bad, and that can be enough to push them to have surgery. So my feeling is that most patients get better with conservative treatment in general, unless they have a truly structural problem. And again, unless they have a significant neurologic deficit, or they have severe intractable pain, or they're having incontinence or some kind of bowel or bladder dysfunction. Those are the three reasons that we kind of really operate on people, right? If you come back to me and say, look, I can't live with this, I got to cut my leg off, that's a reason for surgery. And you have a finding that's real, that fits that. If you come in, you have a foot drop, and you have some pain and you're slapping your foot and you have a big disc, sometimes those, we would be more quick to operate on that patient because we think those patients get better quicker. Okay. The third one, if you have any type of real bowel and bladder, in other words, if you have incontinence where you didn't really feel that you had to urinate and you urinated, in general, if you had a huge disc herniation or stenosis or some other lesion, that would be an emergency. It's hard to separate out as we get older with men with prostate issues, women who've had multiple kids and have urinary incontinence, stress incontinence. Those we factor that in. But if someone came in and said, I just peed my pants and I didn't feel it, and we had a big disc herniation, that would be an indication for immediate surgery. So I don't have a problem with people living with most of their conditions, and not having surgery. And patients always are worried that they're going to make it worse, but we're all going to get older and the picture might look worse. But if you're fine, you're fine, and we treat you. It's not the picture that we're treating. Hopefully that helped. So what's the recovery look like for spinal fusion surgery? So there are tremendous variability in that, depending on if you're having a one-level fusion, right? So I had a question about L4-5 spondylolisthesis stenosis. So that would be a one-level fusion, because L4-5 in the disc is considered one segment, versus someone who has scoliosis and needs a T4 to pelvis fusion, much bigger operation, many more hours, much bigger operation. So usually for 1, 2, 3 level fusions, I tell people look, the first, 2 or 3 days are going to really stink getting in and out of bed, because it just hurts to get in and out of bed. And the quicker you get out of bed and the quicker you walk around, the better you do. There's just no question about that. We do the vast majority of our 1-level fusions, we tend to do minimally invasively, which is 2 small incisions. And basically what you're doing is you're dilating the muscle. You're not cutting through the muscle or stripping the muscle off the bone. You just put a little dilator down to the bone, and then you put a little tube over the dilator, and then you can work through that tube. And when you pull the tube out, you actually can't even see where you are operating. And that reduces blood loss. It reduces the tissue trauma related to the retracting. And it definitely reduces the pain medication. So people have a quicker return to their normal activity. And you can just see the difference if someone's had a 1-level open surgery versus a minimally invasive. In general, the patients are moving quicker with the minimally invasive surgery. But in the long run, it doesn't matter. Both of those operations are perfectly fine. So I always tell patients the first couple of days are really not fun. You're going to be wounded for at least a couple of weeks. You're going to be sore for 4 to 6 weeks. But you should be up walking around the day of surgery, assuming it's a smaller fusion, 1, 2, 3 level versus a scoliosis. But even the scoliosis patients should get up the next day and walk around. We usually have people heal about 10 weeks to 12 weeks, basically just walking, doing stairs. And then when they come back at about 10 to 12 weeks, that's when the bone would be the fusion would start to get sticky. And so then you'd start people with physical therapy to do back abdominal strengthening exercises. So I think you can continue to improve and get better and better shape for 6 months, 9 months. But when you wake up, if you have back pain and leg pain, and the reason you're having surgery is for the leg pain, the vast majority of patients just wake up and say, my leg pain's gone or 90% gone. So they're happy. They know that they have the incisional pain, and they know that that will go away. So that immediate relief is very nice to have, and then you can focus on just letting the recovery occur. What new non-surgical treatments are there for chronic neck pain leading to headache and brain fog? So chronic neck pain is tough. I mean, the first thing to do is, make sure that there's not an obvious structural problem. A lot of those are muscular issues. A lot of people have cervical migraines. The headaches start with knots in their neck, and then they go up over the top of the head. That's really more neurology that manages that in combination with our pain management people. So that's not a surgical issue, fortunately, in general. But a lot of times people can get better if they have trigger point injections, physical therapy, really to try and get rid of the knots that are in the neck. Sometimes I've seen a lot of patients now being treated with Botox for that. So you do the trigger point injections. If their headaches get better, then a lot of times either the neurologist or the pain management specialist will try Botox for that. And, but it lasts like 3 months usually. And that can really help alleviate those kind of headaches. I don't know about the brain fog issue. That's more of a neurology question. But it's not uncommon for people to have neck pain and then have headaches related to the muscles in the neck. Because if you think about it, the muscles in the neck actually attach pretty high up on your skull. So when people say, gee, it hurts on my skull, it's really their muscles of their neck. And if you need 2 hip replacements, what is the relationship to success with spinal surgery? So it depends on what surgery you need. They're separate issues specifically, and it depends on which is worse. So, for example, we see a lot of patients who have spinal stenosis in their back, and then they have a degenerative hip or 2. It's not uncommon, just like we see patients with neck issues and shoulder issues all the time. In general, it just depends on which problem is the worst problem for the patient in terms of function, right? So if you have some groin pain related to your hips that need to be replaced, but you can't walk 10 feet because you have, or 2 block because you have severe spinal stenosis, then we might choose to fix the stenosis first, because then you can recover from the hip surgery much easier because you can walk the distances you need to walk to get better. if you have severe acute pain in your hip and you have spinal stenosis, sometimes we'll have patients get an epidural injection in their back and then have the hip replacement if the real acute issue is the hip. So I think those are two different things. We have plenty of patients who've had hip replacements and back surgery. It's not uncommon. It's actually very common. How often can you get steroid injections in your spine? So in general, we say 3 injections over a 6-month period, and then you're supposed to wait 6 months before you get more. Sometimes you could sneak a 4th one in there, depending on how the dose that the pain doctor gave you or not. And the reason is because it can suppress your adrenal glands and cause issues. So if too much steroid is not good. And so 3 injections in a 6-month period, and then you need to take some time off between then. So some people like to give injections. Hey, I'm going to give you 1 this week. I'm going to give you 1 in 2 weeks. I'm going to give you 1 in 3 weeks. And in general, I don't really advise that. I'd get the first injection, and if you feel better for 6 to 8 weeks, I wouldn't go get a second injection in 2 weeks because you just burned your second card. So I would just wait and then come back for the next injection when you had a problem. If the first injection didn't work, I would try a second injection sooner. And then if that didn't work, I wouldn't do another one because it's not really helping. I'm a 75-year-old male, had a lumbosacral L2 to S1 stenosis in May. Much going on for anterior other surgery. I'm not sure if that ANT, I'm not sure what you meant by that. If you have spinal stenosis, again, from it looks like L2 to sacrum, then basically the treatment for that is, if you're not getting better conservative management, the treatment would be to do a laminectomy. If you have a structural issue with that, like scoliosis, spondylolisthesis, then the surgeon may recommend a spinal fusion, again, because think about it this way: if your spinal alignment is normal and you have spinal stenosis, the treatment is just to remove the bone to free up the nerves. If you have a structural issue, spondylolisthesis, the slip of the bone, or scoliosis, a curvature, and you have to take off a lot of bone in order to free up the nerves, you're making the already, quote, basically unstable condition worse. So then you'd have to recreate a tension band, which is to perform the fusion in order to recreate a tension band to recreate the stability of the spine. So most people with spinal stenosis with normal alignment of their spine just need a laminectomy if they need surgery at all, right? If they have those structural problems and you do the laminectomy and you don't recreate the tension band, then you have a much higher rate of needing a reoperation down the road. What is the recovery time for surgery for stenosis and spondylosis? So spondylosis is just aging of the spine. It's degenerative changes of the spine. I have some gray hair. It's looking in the spine saying, oh, you have spondylosis, means, it's just an aging spine. That goes along with degenerative disc disease, which again is just aging of the spine. Facet arthrosis or facet arthritis, if you will, again, aging of the spine. So in general, for spinal stenosis, the more levels you need, it's a little bit bigger recovery. So I think that patients usually, if we have 1 level of stenosis at L4-5 and no structural issue, younger patients, we've been doing them as outpatient surgery. Even 2 levels. A couple weeks ago, I just had a patient who had L3-4, L4-5 stenosis, and he wanted to have it done outpatient, perfectly fine. If you're older, then usually you're in the hospital a day. If you have a bigger surgery, like one of the questions above, from L1 or L2 to S1, you usually overnight. Sometimes people stay a couple days. If you have a lot of medical comorbidities or you're older, in your 80s, then you might need to go to rehab, but it's pretty uncommon to need to be in the hospital more than a couple days for spinal stenosis surgery, just for stenosis surgery alone, not for doing a fusion or anything like that. So I have a pain in my right and left glute. no back pain, usually at night or in bed when I'm sitting. They say it can be from my spine. When I press, it's painful. And some pain in the peroneus longus, which is on the outside of the leg. Don't know if it's muscle or tendon. So, I mean, I think that someone like that needs to be evaluated in the office, right? Because the first thing we want to know is, do you have any weakness? Do you have any numbness that you might not have noticed? Do you have x-rays that show a structural issue? If none of that, if none of those occur, then you could try some anti-inflammatories, oral steroids, physical therapy. If that didn't work, then you'd get an MRI. If the MRI showed severe stenosis, then you'd consider an epidural injection or surgery. Can a laminotomy be done for spinal stenosis coupled with spondylolisthesis as an alternative to spinal fusion? So the answer is you can definitely do a laminectomy for a patient with spondylolisthesis, the slip of the bone, right? We talked about that. And spinal stenosis, this guy showed over here. So here's the spondylolisthesis. This lines up perfectly. And then here's the little, you have to make a right-hand turn to get over here. And here's the stenosis. So there's been a few good studies out there that have actually shown that if you do a laminectomy in a patient with spondylolisthesis and stenosis, and you don't do a fusion to recreate the tension band, that you're 4 times more likely to come back for surgery. So to me, it's a no-brainer. If I had a spondylolisthesis and stenosis, I would absolutely want them to fixate that area, because I always think about it as recreating a tension band that you're removing to treat the problem. And the problem is 2 problems. 1, it's the stenosis, which is causing the leg pain. And 2, it's the spondylolisthesis, which is unstable. So the reality is that you're more likely than not going to need another operation if you do that. You might get away with it, but you'd definitely be in the minority. Is spinal cord stimulator treatment reasonable for the relief of pain and spinal stenosis? In general, that answer is no, unless you're so sick or have a very short expected lifespan that you might opt for that option. But in general, for me, spinal cord stimulation, which if people don't understand what that means, it's a lead is placed in the epidural space. So if you think of when women have babies, they have epidurals, right? They put the catheter in there. It's the same kind of approach. They put a catheter in, but it goes up to your spinal cord usually around T10, 11-ish, somewhere in there. It can be a little higher or lower. And it stimulates the spinal cord, which theoretically gates the pain that you feel in your back and in your legs. It's better for foot pain than it is for knee pain, than it is for butt pain, than it is for back pain. But things have advanced very, very well over the last 15 years. But I look at spinal cord stimulation as kind of a last option. The treatment for spinal stenosis, if you fail conservative therapy, is surgery. And to do an operation that doesn't address the problem makes no sense to me. Now, if you had a surgery for spinal stenosis and you had back pain and it was debilitating, which is uncommon, but let's say you did, and you weren't unstable and didn't need a fusion, for example, then it would be completely reasonable to try to have a trial of a spinal cord stimulator. But if you have true spinal stenosis with severe compression of the nerves, it makes no sense that you're doing the wrong operation when there's a perfectly good operation to fix that problem. I read that NSAIDs like meloxicam used prior to COVID vaccination can be problematic. I'm not an infectious disease specialist, and I don't have an answer for that. I've not heard anything about that. I don't tend to use meloxicam because I think a lot of the over-the-counter anti-inflammatories are just as good. I'm taking gabapentin for nerve pain, is there any there are a lot of side effects with gabapentin. It can definitely make you spacey, but clearly you're tolerating it. It can have you put on weight. Patients can take it for the lifetime if they need to. It's just a question for me, if you have nerve pain and you don't have a specific problem that can be treated with physical therapy, injections, possible surgical intervention, then gabapentin's a good drug. And if it takes the edge off and you have some, for example, spinal stenosis, and you're on gabapentin and said, I'm fine, then you could live with that. But again, definitive treatment of certain conditions that fail conservative therapy require surgery. But you can definitely take it, but there are plenty of patients who take it for life. It was originally developed as a seizure drug, but it wasn't a great seizure drug, but it was a really good nerve pain drug. Can stenosis and spondylosis cause acute dizziness and acute fatigue? No. They have nothing to do with dizziness. Obviously, if you have pain in your back, your back can fatigue, and you can feel fatigue just from dealing with the pain of it, but it would definitely not have anything to do with dizziness. Your opinion on using Cymbalta for nerve pain and stenosis. So there are a few drugs that you can use for nerve pain. Gabapentin is one of them. Certain antidepressants, not being used as an antidepressant, is the second category, and most commonly is Elavil or amitriptyline. Cymbalta is definitely a good one. Some of the insurance companies approve it or don't approve it. It has an indication, I think, for diabetic neuropathy, which is a nerve type pain, and it works in that situation. I don't have a problem with people trying anything within reason to give them relief. But again, when spinal stenosis, so if I go back to the example of I-95, if you think of 8 lanes as being fully open, anything less than 8 lanes is stenosis. So if you have 7 lanes open, like driving in the middle of the night, it's definitely not a surgical problem. If you have 1 or 2 lanes open, it's definitely a surgical problem. And usually once it becomes symptomatic, it won't get better. It kind of waxes and wanes. You can do shots, you can try therapy, you can stay in bed and all that stuff. But eventually, as you continue your activity, once it becomes symptomatic, then sometimes you just need surgery. And so I don't have a problem with trying Cymbalta, just like I don't have a problem with trying some gabapentin. I don't think that really works long term for stenosis, because the stenosis is going to progress. So think about it as throwing cement on I-95 for the 50, 60, 70 years you're alive. It doesn't go away like a disc herniation. Sometimes when you have a disc herniation, if you can just wait it out for a while, the disc will desiccate, get smaller, lose its water content, and the nerve will feel better. And most people with disc herniations get better without surgery. Spinal stenosis is one of those slowly progressive things, because the problem is it doesn't go away. Someone just keeps throwing cement on I-95, and eventually you get to a point where you're like, okay, I have to deal with this. And so it's a different condition. What specialist is best to diagnose trigeminal neuralgia? So trigeminal neuralgia is usually treated by neurologists. There are a lot of neurosurgeons who do surgery for it. There are some neurosurgeons who have clinics for it. We tend not to treat that here, but there are procedures to do for that, which people can have certain types of rhizolysis. You can use Gamma knife. Most of the time, patients get treated with medications. So there are some neurosurgeons who have kind of a little specific practice in that area. A lot of times it's just managed by neurologists. And then if you fail with the conservative therapy from the neurologists, then they might refer you to a surgeon to do your options, which is basically kind of an ablation of rhizolysis of the nerve, or a surgery. Sometimes there's a little vessel that's pushing on the nerve, and you can put a little Teflon pledge it between that, and that'll fix the problem. Or sometimes you can use a gamma knife, which is a stereotactic radiation to actually target the nerve. And those are kind of the 3 surgical treatments for it if you fail conservative therapy, which is, it's a pretty small percentage of patients. I missed the beginning, sorry. Can you talk about sciatica? So sciatica is basically pain down the leg. Some people also use the word radiculitis. That's not so common. Sciatica refers basically to the sciatic nerve, but there's another nerve that goes down the leg called the femoral nerve. So sometimes when patients have pain in the front of their leg, they say I have sciatica, but for the doctors, we're more specific about where the lesion, where the problem is. So in general, sciatica gets treated conservatively, and the vast majority of patients get better without any kind of intervention. So anti-inflammatory, rest, activity modification, anti-inflammatory medications, physical therapy, chiropractic care, acupuncture, massage, all of those can work, home exercise program. And then if it didn't get better, you could try something step up, oral steroids. If it didn't get better, MRI, because you want to know what the issue is. You want to make sure that you don't have a really weird lesion or something that's causing the problem. Most of the time it's self-limiting. And then if the MRI shows something, then you could consider an epidural injection, additional physical therapy. If it persisted and you failed all those treatment options, then you might consider surgery, assuming that the pain you were having fit perfectly with the exam and perfectly with the picture that was taken with the MRI. Is there surgery that can be done for chronic inflammation of the SI joint or the sacroiliac joint? So let me, for those who don't know, so the sacroiliac joint, if you think about your butt bone, your sit bone, and then your pelvis comes off of that, there's a joint there, and it's an oblique type joint. A lot of women have problems with it. It's less with men, but particularly once women have had a couple kids and stuff, that the pelvis is a little unstable sometimes, and so patients come in with quote back pain or butt pain, and it's really their sacroiliac joint, and it can go from very mild to miserable, and sometimes it can irritate the sciatic nerve. So patients can have the pain and present with sciatica, and it's hard to figure out early on whether or not it's the SI joint or whether it's a problem with your back. And so the answer, usually treatment for SI problems is, again, a course of rest, activity change, and then anti-inflammatories. Like when I say anti-inflammatories, I mean like 2 Aleve twice a day for 10 days with food, or 600 milligrams of ibuprofen and Motrin 10 days with food. If you can try, if you come to us and you say I tried that already, we might give you an oral steroid pack, because the oral steroid is like a sledgehammer compared to a hammer of the anti-inflammatories. And then physical therapy, a lot of times just strengthening one muscle, or trying to get the pelvis being stable again, which is just a lot of different types of exercises, usually can take care of that problem. If it fails, then the pain doctors could do an injection into the SI joint as both a diagnostic and a therapeutic maneuver. If they have to do that under X-ray though, because the joint's oblique, so you can't really tell you're in the joint unless you actually look at it under X-ray. So they would do an injection, and the injection has 2 parts. One is a numbing medication, one is a steroid. So if you get off the table and you go, wow, that feels really good, that's diagnostic, right? Because you had a toothache, they injected your tooth, it went away. So if you had pain there and they injected it, it went away. And then the steroid takes like 3 to 7 days to work. If that helped for a while and then came back, you could consider doing an ablation, which is to cook the nerves that go down to the SI joint, which sometimes can give you a year, 2 years of good relief. If you fail all that, then you can fuse the SI joint. Now there's some minimally invasive approaches to doing that, There's some controversy about if you do one side, then do you kind of change the dynamics of the pelvis, and are you going to develop it on the other side? I don't know that that's really been enough cases have been done to really see that. Dr. Simon, who's in our practice, has done a fair number of them for patients and has had excellent results. So it's certainly worth talking to him if you've failed the conservative approaches first, but a lot of times patients fall down the road and one of those conservative approaches works for them, and then they don't need the surgery. So the answer is yes, that you can definitely have an SI fusion if you failed conservative therapy for sacroiliitis. What else regarding sciatica? What else masquerades as sciatica? Well, sciatica is really a symptom, right? You say to me, I have pain down my leg. There are a number of different things that can cause pain down the leg, right? The most common is degenerative conditions of your back, or a disc herniation, stenosis, things like that are very, very common. Rarer things are tumors. Obviously fractures can cause that. The sacroiliac joint, sometimes it gets inflamed so much that the sciatic nerve is living right next to it, so it gets inflamed. And sometimes the piriformis muscle, which is a small muscle in your butt area, that can get really tight, particularly like in runners and a lot of people who are very active. And sometimes the sciatic nerve lives very close to it, actually all the time, but sometimes it lives inside the muscle, it kind of passes through the muscle. I think they say about 15% of the time. So if that muscle gets tight or inflamed, people get sciatica. So then they come in, we try and evaluate them, and we have to sort that out and say, oh, I think this is really coming from your back. It's not the sacroiliac joint, the piriformis area. In rare cases, you can actually have tumors of the sciatic nerve, which benign tumors, and they present, and we've seen actually a couple of those in my 20 years here, which are kind of out in left field, but you just have to keep remembering that that's a possibility. It's rare, but it can happen. So I think those are kind of the main. What are your thoughts regarding cervicogenic vertigo? It's not an area that I specialize in. I definitely know that can happen, but in generally, when we think of cervical issues and dizziness and vertigo, we think of the vertebral arteries, which come up in the cervical spine. And is that part of the problem? Usually you're evaluated by ear, nose, and throat for any type of ear issue obviously with the vertigo and neurology. It's uncommon for degenerative changes in the neck to cause vertigo and dizziness and motion sickness. I've rarely seen anyone with those type of complaints. You usually start thinking of vascular issues or ENT type issues. So I'm assuming that you've been evaluated by an ENT and by a neurologist, because those are the two people that need to work it up. Obviously, the workup you've had, it sounds like you've had an MRI of your neck, but I don't know if you've had an MRI of your head, and also a study looking at the vessels of your neck and your head, because that's all important. Don't steroid injections or oral steroids cause osteoporosis and bone loss? So if you take them in short amounts, and I want to say one thing about the steroids, they're glucocorticoids, so they're different than the steroids you hear about from the athletes that are injecting the steroids. Those are a different category of steroids. If you're on steroids, for example, there's some patients who have lupus, some patients have rheumatoid arthritis. There's a number of conditions that patients just need to be on steroids, COPD, for example, which is a lung problem, that you need to be on steroids for a long period of time, because the risk of being on the steroids is less than the risk of being off the steroids. In those patients, you definitely can develop osteoporosis and bone loss. Absolutely no question. We take care of a number of people. Usually it's elderly women who've been on steroids for a number of different causes, which they need to be on. And then they can sustain a vertebral fracture, which we can treat with a minimally invasive cementing procedure called kyphoplasty if they have it. But there's definitely no question that long-term steroid use can cause osteoporosis and bone loss. Short-term use that's not the case. So the steroid pack, the Medrol dose pack that we give you is the same pack we give kids for poison ivy and for bee stings, and that's why it's a taper, so that you don't get a huge dose and then it suppresses your adrenal gland. So that in general, the short-term steroids, the main thing I tell people with oral steroids is it can bother your stomach, can cause, you could theoretically get an ulcer. It can bump up your sugar. So if you're diabetic, you have to think about it, at least know that it can occur. In rare cases, it can suppress your immune system. And it can also cause AVN of the hip, which is basically avascular necrosis of the hip, where because there's a little vessel that goes to your hip bone, and sometimes that can be affected, and you can have a problem with your hip. But in our practice, oral steroids are given out a ton, and that's a pretty rare complication. Doesn't mean it's zero, but again, it's like driving your car every day. Most people don't get an accident, but someone does. So we're not giving it out lightly. We're giving it out only usually short term. So I don't think that short-term use of steroids would cause osteoporosis. At what point do you need MRI to diagnose sciatica? So that's changed a little, sometimes from the insurance companies and sometimes from the docs. So we know that most of the time sciatica gets better on its own. Sometimes we need to help you with it, right? Because the pain is so much that you want to take some oral steroids or some pain medications. If you have spasms in your back, you might need a muscle relaxant. There's a number of things we can do to try and help you facilitate your recovery. Then go to physical therapy where they can work with you to help get you mobilized again. So in general, I think it's fair. A lot of times people come in and they go, I have sciatica, I want an MRI. But the reality is, I say to them, well, if I get an MRI today, are you going to let me operate on you tomorrow? And the answer is no. And I'm like, okay, then you don't really need an MRI, because the likelihood that it's something other than the most common thing is really low. So a lot of the insurance companies have changed pretty much across the board now. It's over the past 2 years, it's been happening more and more, that you have to do 6 weeks of physical therapy before they will even consider doing an MRI. Obviously, there's caveats, right? In a patient with significant neurologic deficit that I document in my chart, or in the neck, spinal cord, if I think something's being pushed on the spinal cord, that is a totally different category. But in general, for sciatica, if you came in for sciatica and you had terrible sciatica and you weren't getting better with rest, activity modification, anti-inflammatory medications, I give you an oral steroid. It's pretty uncommon that you need to take a true pain medication like oxycodone. Sometimes tramadol or Ultram is a good mid-range for people who are really in pain, but sometimes just 2 extra strength Tylenol 3 times a day helps, even though that's not an anti-inflammatory. And then if you go to physical therapy, the vast majority of patients will come back and say, I'm getting better. The vast majority. So you save an MRI, you save putting a patient in the MRI, you save the patient and the insurance company the MRI cost. So usually if you're failing physical therapy, or if you get worse, you go to physical therapy 2 weeks and you're like, holy cow, I'm worse, then that would be an indication for an MRI. But if you came with a complete foot drop, you need an MRI like in the next day or two, Thank you, Betsy, an old-time friend. I don't see any more questions. I'm happy to stay all night and answer any questions that you want. I guess there's no more questions. Oh. Is Celebrex a better anti-inflammatory than something like Relefin? So I think that all of the non-steroidal anti-inflammatories, when you look at them across the board, it's kind of like a car. The car will get you from one place to the other. It's just that you like that car and I like this car. So some patients will say, gee, Relefin, I love Relefin. I love Voltaren. I love Meloxicam. I love Celebrex. I mean, the idea behind Celebrex is that it has less likelihood of affecting your stomach, and that's the selling point of it, and that's definitely different. So Celebrex and meloxicam are the two that don't bother the stomach. Vioxx was, but that had issues with cardiac problems, so that's why it's taken off the market. So Relefin was kind of in the middle where it had less effect of the stomach, but it wasn't in the same category as the other two. So I look at them all from a potency point of view. They all do the same thing. It's just if you have to be on something chronic, then sometimes people will use Celebrex and meloxicam because theoretically it won't bother your stomach, or cause a stomach issue. I had 2 shots in my piriformis, but my leg still hurts. I'm assuming that you had an MRI of your back first to make sure that you didn't have a structural issue with your back. So if you had 2 shots in the piriformis without an MRI of your back, then you need to have an MRI. Okay, yes. So you said that. So if the MRI is negative, which I'm assuming it is, and you had the shots, really the most important thing to do is PT, and piriformis can be a real bear to treat. I often tell my patients, if someone's not putting their elbow into your butt and really digging in, or using the tools that they have now, the Graston tools, really digging in, that you might not get better. And I've had it when I used to run, and it was a bear to get better. It lasted for about 3 months for me, and then eventually just kind of went away. But I've seen patients who have it off and on for a while. I think there was another question. Hopefully that answers the question. But I mean, the shots are kind of a pretty aggressive approach if the PT is not working. Would the neuropathy that I have in my right foot be associated with my sore back and sciatica? So a lot of patients come in and tell me that they have neuropathy of their feet or foot. And neuropathy is a little different than sciatica, right? So, or, because sometimes you'll have some numbness and tingling in your foot, or some numbness in the foot. And I've definitely seen a number of patients who come in with the diagnosis of neuropathy and tell me they've had it for a while and they're not getting better. And we get an MRI and we see that they have spinal stenosis. Usually that can be it. And sometimes if a patient has severe stenosis and they get operated on, they'll tell you, oh, my numbness in my foot is better. But obviously if you're diabetic, then you could have 2 problems. You could have a problem with your back, but you could have a problem with the diabetes that causes a neuropathy in the foot or both feet. And that may or may not get better with surgery. So sometimes when patients are diabetic, I say, look, you have very bad stenosis and you can't really walk any distances and you failed therapy, so we should consider treating that. But remember, you have the diabetes. We're not sure if the numbness is related to the diabetes or the stenosis. And sometimes patients come back and the numbness is much better after the stenosis surgery. And then they say, oh, I guess I didn't really have it from the diabetes. So the answer is yes. And if you haven't had an MRI, you should have an MRI of your back. My pacemaker is not MRI compatible. What other tests could I have? So the MRI is the best test for the spine. You can't have that, obviously, because you have a non-compatible pacemaker. So a CAT scan is the next best test. If we really were worried about spinal stenosis or a disc herniation, in other words, if you had severe leg pain, then unfortunately you need a myelogram. So a myelogram is, let me just go over here and see my little spine. Myelogram is basically a lumbar puncture where they put a needle coming in here into the low area, just like a spinal tap. And then what the radiologists do is they take out some spinal fluid and then they put in some dye, and then they tilt you upside down a little bit so the dye runs around in the spinal column, and then you go for very thin slice CAT scan. And that basically shows you the spine. It's not as good as the MRI, but it's definitely good enough to treat like a disc herniation or stenosis. But when you see a picture on an MRI like this, if a piece of disc is sticking out over here, you'll actually see the disc. But if you look on the myelogram or the CT myelogram, you don't see the disc. You see the sac looks open, and then all of a sudden it's closed in the area, and then it opens back up, and you say, oh, there's a disc there. Oh, there's stenosis there. So you can definitely be worked up. Sometimes if we're really not at a point of surgery, you can just get the CAT scan. But if there's a lot of degenerative changes, the CAT scan in and of itself is not helpful. Would ablation help piriformis? I definitely have not heard of ablation for the piriformis muscle, because ablation is the problem with piriformis syndrome is that the muscle is tight and spasm. It's really tight, and ablating the nerve doesn't help. I don't know if people are using Botox. That might be the question to ask one of the pain doctors, right? So if you had a shot and it helped for a little while, and then it came back, then sometimes something like Botox might help, but I don't know if that's standard treatment. That's really more in the realm of pain management, not in the realm of neurosurgery. And I'm assuming your diagnosis is correct. I don't know. So happy to answer any more questions. One more call for questions. Oh. Thank you too for coming. Okay, well, if there are no more questions. Will walking hurt my piriformis? No, you can walk as much as you want. Well, thank you too. Thank you all for coming. Hope you all stayed warm and safe in this exciting storm we had. And if you have any other questions, you can email Cindy, and I can get back to you on them. If you just think of one, of course you will once we hang up. Okay.